So now with that, I will move on to introduce beautiful Dr. Lauren Lee. She is a senior guidance writer for the VDH Health Information Team. She knows a lot about a lot. She has also been the co-lead of our clinician outreach team, which was responsible for putting this training together. She was educated at Williams College and then got her medical degree at Washington University School of Medicine in St. Louis. She did her residency at the UCLA Medical Center and then went on to get her master's in public health and epidemiology at University of California, Berkeley. She's previously worked as a medical epidemiologist in communicable diseases at the state and local health departments in California. And she's been the subject matter expert for various infectious diseases, including several respiratory, foodborne, and fungal infections. And today I introduce her to you as an expert in Mpox. All right, thank you, Lauren.
All right, well, thank you so much for coming out today. It's a pleasure to be here. As Jenny mentioned, this is our fourth and final in-person Mpox training session, and it's great to see so many people out today. So I'm going to start with an overview and some background on Mpox, and then we'll move on to talk about the epidemiology of the 2022 Mpox outbreak. I'll go over a few ways providers can collaborate with public health, and last, I'll share a few resources. So let's start with some background on Mpox. Mpox is a rash illness caused by the monkeypox virus, which is an orthopox virus. It belongs to the same group of viruses as smallpox, and it's a zoonotic infection, meaning that it can spread between animals and humans. Before the 2022 Mpox outbreak, Mpox was rare in the United States. Symptoms are similar to smallpox symptoms, but they're milder. And the type of Mpox that's been seen in the current outbreak is rarely fatal. More than 99% of people who get this form of the disease are likely to survive. And Mpox is not related to chickenpox, even though they do have similar names. So Mpox was first discovered in 1958 in Denmark when there were 2 outbreaks of pox-like disease in monkeys that were being kept for research. The specific animal reservoir for Mpox is unknown, but non-human primates and African rodents might harbor the virus and infect people. The first human case was reported in 1970 in the Democratic Republic of Congo during a time of intensified efforts to eliminate smallpox. Monkeypox virus is a DNA virus in the genus orthopox virus. This genus also includes variola virus, which is the virus that causes smallpox, vaccinia virus, which is the virus used in smallpox vaccine, and the cowpox virus. The virus has 2 distinct clades that were renamed by WHO experts in August 2022 so that the names would be in line with current best naming practices. Clade 1 is the former Central Africa or Congo Basin clade, and this clade causes more severe illness with a case fatality rate as high as 10%. It also spreads more easily, so more person-to-person transmission is seen with clade 1. And clade 1 is classified as a select agent. Clade 2 has largely been identified in the current outbreak. It's the former West African clade, and historically this clade has caused less severe disease, and it's not classified as a select agent. Clade 2 consists of 2 subclades, 2A and 2B, and clade 2B is the one that's been largely circulating in the current outbreak. Now, in recent years, the epidemiology of Mpox has been changing. Before the 2022 multi-country outbreak, Mpox had been reported in people in several Central African countries, like the Democratic Republic of the Congo, Central African Republic, and Republic of Congo due to clade 1 virus, and in Western African countries, including Nigeria and Sierra Leone, due to clade 2 virus. And in these older reports, human cases were reported for mostly rural forested areas in the Central and Western African countries, or in countries with cases related to migration or travel, or in people who had been exposed to infected animals. Now, since 2014, the annual number of Mpox cases has been increasing in Africa. And this reemergence of Mpox might be due to a combination of factors, including environmental and ecological changes, animal or human movement, the end of routine smallpox vaccination since it was eradicated in 1980, improvements in disease detection and diagnosis, as well as genetic changes in the virus. And from 2018 to 2021, human cases were reported from 6 African countries, and DRC and Nigeria reported the most cases of clade 1 and clade 2 virus, respectively. Now let's transition and talk about Mpox cases here in the US. Cases in people outside of Africa have been linked to international travel or imported animals, but these reports were not common. In 2003, there was an outbreak of 47 Mpox cases from 6 Midwestern states, and all people who were infected with Mpox in this outbreak became ill after having contact with pet prairie dogs. The pets were infected after being housed near imported small mammals from Ghana, and this was the first time that human Mpox was detected outside of Africa. And the investigation found that no infections were caused exclusively by person-to-person contact. And there were no additional reports of Mpox in the US until 2021, when 2 travel-associated cases were reported. And both of these case patients had traveled to Nigeria. CDC and state health departments investigated these cases, and they found no further Mpox cases in the US. Next, we'll move on to discuss the current 2022 multi-country outbreak. In early May 2022, UK health officials announced a confirmed Mpox case in a person returning from Nigeria. And additional cases were identified in the UK, and some occurred in people who had not traveled to an endemic area or had a known epidemiologic link to other cases. The number of Mpox cases rapidly increased and expanded to other countries, and it was noted that these cases were primarily occurring among men who have sex with men. The first US case was reported on May 17, 2022 in a Massachusetts resident. And on May 23rd, CDC launched an emergency response that emphasized surveillance, testing, medical countermeasures, and education. Additional cases were reported in the US, and the first presumptive case in Virginia was reported on May 26th, and it was confirmed by CDC the following day. Now, cases to date have been reported in all 50 states, Washington, D.C., and Puerto Rico. All cases have been clade 2, specifically clade 2B. And WHO declared the outbreak was a public health emergency of international concern on July 23, 2022, meaning it was an extraordinary event that posed a public health threat to other nations through the spread of the virus, and it required a more coordinated international response. And that WHO declaration ended on May 11, 2023. The 2022 Mpox outbreak has been unprecedented with its worldwide spread and emergence of cases in countries that have never reported Mpox before. And it was the first time that there was sustained person-to-person transmission, primarily spread through sexual contact. This figure shows the distribution of Mpox cases across the world, and the orange dots represent countries that have not historically reported Mpox, while the blue dots represent those countries that have historically reported Mpox. Larger dots, like the one showing the US, indicate a greater number of cases reported from that country. And as of February 7th, more than 93,000 Mpox cases have been reported from 118 countries, with 177 total deaths. This figure shows the epi curve by month for cases from July through December 2023. And as of that date, the majority of cases from the past 6 months were in the Western Pacific region, represented in this figure in green, followed by the region of the Americas in blue and the European region in red. 96% of the cases with available data are males with a median age of 34 years, and males 18 to 44 years old make up 79% of the reported cases. Sexual encounter was the most commonly reported transmission event. And for cases with information available, 85% identified as men who have sex with men. 52% of Mpox infections were in people with HIV, but these data were not available for the majority of cases. Now, during this outbreak, the US has had the most Mpox cases of any country, with more than 31,000 cases across all 50 states, Washington, D.C., and Puerto Rico, and 56 deaths, with 2 of these deaths being reported in Virginia. And this map shows US Mpox cases by state. Darker shade represents state with more cases, and lighter shades represent states with fewer cases. The hardest hit states have been California, New York, Texas, Florida, and Georgia, and Virginia ranks 13th. There have been 582 Mpox cases in Virginia. And in the US, the total number of Mpox cases has been trending downward since late August 2022, but there's variation in trends based on state and region. And CDC does continue to urge health departments, clinicians, and the public to remain vigilant, institute appropriate infection prevention and control measures, and notify public health authorities of suspected cases to reduce disease spread. The epi curve at the top right shows all US Mpox cases, and there is a distinctive peak in cases that occurred in the summer of 2022. And in the center, we can see all of the cases reported in 2023, which are the blue bars, and the 7-day moving average of cases, which is the orange line. And the average number of new cases has fallen from 450 a day in August 2022 to a range of 4 to 8 a day as of December 2023. Now, in the spring and summer of 2023, 2 jurisdictions, Chicago and then Los Angeles, reported an uptick in cases. Several other US jurisdictions, including San Francisco, San Diego, and Oregon, have also reported smaller increases in cases. And these increases in cases serve as a reminder that the outbreak is not over, and we must continue the work to prevent Mpox transmission. This figure shows US cases by age and gender, and you can see the overwhelming majority of cases are in men, represented in the figure in dark blue. And those cases are within the age range of 21 through 55 years. This figure shows distribution of US cases over time by race and ethnicity. And in the early stages of the outbreak, cases were occurring primarily in non-Hispanic white men, seen in the figure in dark blue. But as the outbreak progressed, we saw increasing number of cases in non-Hispanic Black or African American people, seen in the figure in orange, and Latino or Hispanic people, seen here in purple. And disparities have been observed in this outbreak, as Mpox has disproportionately affected racial and ethnic minority groups. When we look at the overall race and ethnicity data in the US, we see a nearly equal distribution of cases, so that about 1/3 identify as Black or African American, 1/3 identify as Hispanic or Latino, and 1/3 identify as white. Last May, CDC authors published a summary of the domestic outbreak response so far, and they described the epidemiology of the US cases as well as the public health response. The authors reported the majority of cases occurred in adult men who have sex with men and in people aged 21 through 55 years old. Similar to what was seen globally, here in the US, the outbreak was also disproportionately affecting people with HIV. 38% of cases were in people with HIV. And as I've mentioned, health disparities were seen among racial and ethnic minority groups. Black and Hispanic people were disproportionately affected by Mpox infection. They also found that the majority of deaths occurred in Black people, and 94% of people who died were also immunocompromised, because of HIV infection that was poorly controlled. And these data highlight that there's overlap with HIV and Mpox infections, and both epidemics are interacting negatively with each other. It shows the importance of integrating Mpox into our routine HIV and STI care. And it also demonstrates there has to be a focus on equity when addressing Mpox prevention, education, and access to vaccines as well as treatments. So let's transition and look at some of the data here in Virginia. This figure shows Virginia's epi curve, and the data are incomplete for the most recent weeks, and that's why the right portion of the curve is shaded in gray, and so those data are subject to change. Now, as of February 13th, there have been 582 confirmed cases, 32 hospitalizations, and 2 deaths. And based on the epidemic curve, newly reported cases peaked in August of 2022 with an overall downward trend since then. Most of the cases were reported in the northern region, followed here by the eastern region and then central, and southwest and northwest regions had the fewest number of cases. Now in 2023, we had a total of 12 sporadic Mpox cases here in Virginia, And in 2024, there have been 4 cases. But there is a small concerning increase in Virginia since November 1st, 2023, with 7 cases being reported across 4 of the 5 regions. And the most recent case was reported in the week ending February 11th. So among those 7 recent patients, 2 were hospitalized, 3 were co-infected with HIV, and only 1 had been previously vaccinated. So again, I just want to reiterate, Mpox is still here. This outbreak is not over. Now, these next few figures focus on the Virginia data from 2022 to 2023. And this figure shows cases by sex, and the majority of cases here in Virginia have been in males. This one shows cases by age group. Cases have been predominantly in those middle age groups, and most were in adults in the range of 20 to 39 years. And this shows cases by race and ethnicity, with Blacks making up the majority of cases, followed by whites and then Latinos. So VDH has taken action to help contain this outbreak as quickly as possible, and this slide illustrates several of those actions. So we do ask healthcare providers to immediately report suspected cases to the local health department, even if testing is going to be performed at a commercial lab. VDH investigates all suspected reported cases and facilitates testing at the state lab, DCLS, if it's indicated. Close contacts are identified by the local health department and monitored. And the local health department also provides counseling to close contacts about post-exposure prophylaxis or vaccine, and the importance of quickly seeking care if patients develop or if contacts develop symptoms. And lastly, wastewater testing for monkeypox virus has been performed in Virginia. The incubation period for Mpox ranges from 3 to 17 days. On average, it's been 5 to 6 days. Mpox spreads when there's close contact with lesions, body fluids, large respiratory droplets or secretions, such as during prolonged face-to-face contact, or contact with contaminated materials such as bedding or towels. And while many cases so far have been in people who identify as gay, bisexual, or other men who have sex with men, anyone can get and spread Mpox through close contact. And most of the spread in the current outbreak has been from close personal, often skin-to-skin contact, including sexual encounters with another person who has Mpox. But there have also been cases in the outbreak due to contact within households, heterosexual sexual contact, as well as sharps injuries, say from a needle or a scalpel. Now, Dr. Oldfield is going to be giving us an overview of the clinical presentation of Mpox, so I won't go over this slide too much in detail. I will just highlight that the presentation of symptoms was different in the 2022 outbreak compared to what was seen with classic Mpox reports. So rash in the current outbreak has frequently been located on mucosal areas, including the genitals, in and around the anus, and in the mouth. And we've also seen rash lesions that are localized to one area of the body, and rash lesions have not always been in the same stage of development. Again, I know Dr. Oldfield will be discussing HIV and Mpox in more detail. I will just remind everyone that in the current outbreak in the US, 38% of people with Mpox have been co-infected with HIV. And most reported cases of severe Mpox have been in people who are living with untreated HIV. So they have low CD4 counts and substantial immunosuppression. So CDC has made several recommendations to providers that are listed here. Highlights include to test sexually active adults and adolescents for HIV and other STIs when evaluating people for suspected Mpox. Consider treatment with TPOXX and encourage people to enroll in the STOMP trial, which is a NIAID-sponsored trial evaluating the effectiveness of TPOXX. It's important to optimize immune function by ensuring those with HIV are on effective antiretroviral therapy, and consider consultation with CDC's Mpox team. They're available both by email or by phone. And this slide summarizes some of the infection prevention and control measures for patients with Mpox. For patients who are isolating at home, it's best if they're isolated in a room or separated from others, if possible. It's important to try and limit exposure to pets and other people. Don't share potentially contaminated items. Avoid activities that can spread lesion material, and routinely clean and disinfect commonly touched surfaces and items. In the hospital, patients should be isolated in a single room with a dedicated bathroom. Staff should use full PPE, so gown, gloves, N95 respirator, and eye protection. Try and limit patient movement unless it's really necessary for patient care. And if a patient does need to leave their room, they should wear a mask and cover their lesions. And staff should avoid activities that can spread lesion material, such as shaking laundry. And while gay, bisexual, and other men who have sex with men make up the majority of the cases in this current outbreak, anyone, regardless of sexual orientation or gender identity, who's been in close personal contact with someone who has Mpox is at risk. There are several prevention measures people can take to prevent infection. Jynneos vaccine, which Dr. Kura will be talking more about later this morning, is safe and it's effective before exposure to Mpox or as post-exposure prophylaxis or PEP. And in terms of timing, it's best if Jynneos is given as PEP within 4 days of exposure to prevent infection or reduce the severity of infection. Other ways to prevent infection include avoiding skin-to-skin contact with people who have a rash that look like monkeypox virus rash. And if you're planning to attend a gathering where you might be in close proximity to others, consider the risk. So having multiple or anonymous sex partners may increase chances of getting Mpox, and temporary behavior change like limiting number of sex partners may reduce exposure. And lastly, washing hands frequently or using alcohol-based hand sanitizer can reduce risk of infection. So let's summarize where we are currently in the Mpox outbreak. Case numbers have declined since peaking in August 2022, and this is likely due to a combination of immunity, both natural and vaccine-induced, as well as some changes in behavior. Now, despite this decrease in cases, public health does continue to monitor Mpox trends and ensure people have access to vaccines and treatment. Since spring 2023, there have been 2 large clusters of Mpox cases in Chicago and LA, as well as some smaller increases in other jurisdictions. And here in Virginia, we've had a small increase recently. So again, these increases highlight this outbreak is not over. On Monday, February 12th, CDC actually sent out an email to clinicians to let them know that small clusters of Mpox continue to pop up here in the US, and severe cases and even deaths continue to occur. CDC reminded clinicians to remain diligent about taking sexual histories and recommend 2 doses of Jynneos vaccine to people at risk to help reduce the spread of Mpox. And on November 23rd, WHO released a report about an ongoing Mpox outbreak in Democratic Republic of Congo. And this was notable for several reasons. First, it's an extremely large outbreak with now over 14,000 clinically diagnosed cases since January 1, 2023. And cases have now been identified in new areas, including large urban areas. And second, the DRC outbreak is caused by a different strain of the virus. It's caused by clade 1. And as I mentioned earlier, there are 2 clades, clade 1 and clade 2 of this virus. And the 2022 global outbreak has primarily been caused by clade 2, but this outbreak in DRC is caused by clade 1. And clade 1 can cause more severe illness and spread more easily than clade 2 virus. And third, this is the first time that clade 1 virus has been documented to spread by sexual contact, including among men who have sex with men. Now, other reasons that this situation in DRC are concerning is that there is stigma against the LGBTQ+ community, and there's also limited or no access to testing, treatment, and Jynneos vaccination. So it really may be harder to contain the spread of the virus in DRC. In terms of infection control, including specimen handling and waste management, clade 1 Mpox virus is categorized as a category A infectious agent and requires more stringent practices than clade 2 virus. Now, the one piece of good news is that we do not expect the performance of diagnostic tests, vaccines, and treatment like Mpox to be different between clade 1 and clade 2. Overall, WHO assesses the risk as moderate for the general population in neighboring countries and for gay men, bisexual men, and other men who have sex with men and sex workers. So CDC is closely monitoring the situation in DRC, and to date, there have not been any clade 1 Mpox cases identified here in the US. And the risk of clade 1 Mpox here in the US is considered to be low at this time. CDC put out a health advisory in December to ensure clinicians are aware of the possibility of clade 1 Mpox in people who have had recent travel to DRC. So if suspected Mpox cases have traveled to DRC in the 21 days before illness onset, for diagnostic testing, you can follow regulations for Category B infectious substances. You want to collect a very detailed travel and sexual health history, contact the LHD to rapidly report the suspected case, and coordinate clade-specific testing through DCLS. So it's important DCLS has approved before shipping of specimens. And DCLS is currently working on validating a clade-specific Mpox test, but that test is not available yet. So until that time, specimens will be shipped to DCLS, and then DCLS will forward them on to CDC for clade testing. We ask providers to remember to swab multiple lesions and collect 2 swabs per lesion. And for waste management in patients who have traveled to DRC, it's important to consider the clinical picture and then also contact your LHD to discuss specifics on how to manage waste. Now I want to highlight some of the ways providers can collaborate with public health during the ongoing response. So while cases and news coverage have substantially decreased, Mpox is still spreading and risk remains. So we ask providers keep Mpox on their radar when seeing patients and continue to promote education, vaccination, and increasing awareness. VDH and CDC web pages have a lot of educational materials available to use as resources, and we encourage providers to integrate Mpox services into HIV and STI clinics and include Mpox on your sexual health checklist. Jynneos vaccine is safe and effective, and it's the best tool that we have to protect people at risk and stop the spread of Mpox. We need to continue outreach and education to the populations who are most affected. Vaccine coverage varies greatly among jurisdictions. CDC put out an MMWR last year that found that despite over 1 million doses of Jynneos being administered, only 23% of the at-risk population has been fully vaccinated. And in Virginia, 19% of those who at risk have been fully vaccinated and 28% have received 1 dose. So we still have a long way to go to close the vaccination coverage gap. If you're a provider and you are not administering vaccine, please consider doing so. We have instructions available on our VDH Mpox vaccine guidance webpage, and they go through step-by-step how you can enroll as a vaccine provider. If it's not possible to get vaccine in your clinic, refer people to CDC's Mpox vaccine locator. And lastly, VDH has quite a bit of Jynneos vaccine that is set to expire at the end of this year. So now is a wonderful time to start planning those vaccine clinics, collaborate with your community partners, and coordinate outreach events so we can use this existing vaccine to protect people who are at risk. If you suspect Mpox, be sure to collect that detailed sexual, social, and travel history for the 21 days before symptom onset. Test for Mpox regardless if a patient has had a history of Mpox infection or a history of vaccination. There have been reports of some patients getting Mpox more than once, though that's not common. And there also have been some reports of patients getting Mpox after having been vaccinated. And remember, when testing a patient for Mpox, also keep in mind to test sexually active patients for HIV as well as other STIs, because concurrent infections are possible and they've been pretty common. And as a reminder, if a patient traveled to DRC in the 21 days before symptom onset, those specimens should be sent to our state lab DCLS so they can be forwarded to CDC for clade-specific testing. And if a patient has not had recent travel to DRC, it's fine for those specimens to be sent to a commercial lab for testing. Providers must notify the LHD immediately if a patient has suspected Mpox infection. We have our online LHD locator that can help you find the appropriate health department. That report can be made online or by phone, and that helps to prompt the public health investigation. And we ask providers to please encourage patients to cooperate with the health department, as that helps facilitate timely follow-up, vaccination, and monitoring of close contacts. And these are a few things providers can do for managing patients with Mpox. If you diagnose Mpox in your patient, consider consultation with CDC for questions about patient management, especially if a patient has a severe infection. We also encourage you to talk to your patients about the STOMP trial. That's the trial looking at the effectiveness of TPOXX as treatment for patients with Mpox. And patients can enroll in the STOMP trial even if they don't have severe Mpox or are not at risk for severe Mpox. And these are a few ways providers can stay connected with public health. We ask that you sign up online for our VDH Healthcare Professional newsletters, sign up for CDC COCA updates and HAN updates. We have a lot of information available on our VDH Mpox web pages. And while this is our last in-person Mpox training session, we'll let you know of future Mpox training sessions once those are developed. Now, this slide lists some of the resources we have available, and I'd like to highlight the last two on this slide. So if you would like to request printed Mpox materials, you can complete the Red Cap survey. There's a separate one for local health departments and another one for folks who are not from the health department. So these are our take-home messages. In general, the risk of Mpox infection for most people is low. The current outbreak has declined substantially since its peak in August 2022, but sporadic cases and some clusters continue to occur in the US, and Virginia has had a small increase since November 2023. In the current outbreak, most people with Mpox have reported close, sustained skin-to-skin contact, including sexual contact with other people. And the current focus is on awareness, education, and vaccination for people at risk for Mpox. Keep Mpox in mind when evaluating patients, especially if they have a diffuse or localized rash. Incorporate Mpox into routine STI and HIV care. Keep in touch with the LHD to report suspected cases, and stay up to date on the information from VDH and CDC. And thank you very much for all of the work that you do in the Mpox response. And I'm happy to answer any questions.